So my name is Zaffer Qasim. I am an emergency physician, a critical care physician in Philadelphia. I also do pre-hospital care with our neighboring New Jersey-based physician response model. And I'm going to be talking to you about the use of whole blood in trauma, whether it's better than the sum of its parts. So unfortunately, hemorrhage has remained a huge problem for us in trauma, and this is kind of exemplified in a case that you might well be involved in on a more regular basis. An MVC happens, for example, EMS responds, there's a requirement for air medical transport to the nearest trauma center. The patient gets offloaded from the aircraft down to the emergency department, eventually makes its way over to the operating room. But if you look across the board across U.S. trauma systems, there is a significant time period that elapses from the point of injury to the point of definitive hemorrhage control and resuscitation in many ways as well. And that means that hemorrhage has remained an ongoing problem. And we see this in a number of studies, including military data, where this paper really looked at outcomes or reasons for death in our soldiers in the recent conflicts, and found that the majority were due to hemorrhage. When you look at the civilian data, we see kind of similar numbers. A significant proportion of patients in this study had potentially preventable death, and a lot of this was ascribed to hemorrhage. This paper out of Miami also kind of showed the same thing, a significant proportion of potentially preventable death, and the majority of those were due to hemorrhage. And when you look at these patients, you'll see that as long as they don't arrive in shock, our advances in trauma center care has really improved outcomes in that subgroup. But the group that arrives in profound hemorrhagic shock, we're still trying to move the needle on those. So why is hemorrhage really a big problem? Well, one of the reasons is that it can affect a number of organ systems and organ functions. There might be direct tissue damage that leads to an endotheliopathy. There is malperfusion at the tissue level, and that leads to metabolic acidosis, which affects a significant number of enzymatic functions. There's an abnormal response to coagulation. The body ends up consuming a lot of the coagulation products and factors, and that actually worsens their response to clotting. And then finally, there might be exposure to the environment. If a body cavity is open, that leads to hypothermia, and that again worsens the body's response to coagulation. So our typical response over decades has been to provide crystalloids to resuscitate these patients, and unfortunately that's still practice in some systems, both pre-hospital as well as in-hospital. But unfortunately, this just exacerbates the problem, right? You're giving a cold acidotic solution which worsens the hypothermia, worsens the acidosis. You're not replacing any of the coagulation factors or the cells that are being lost, and so you're really not solving the problem. And I like this quote from Andre Kapp. I'll leave this up here, but it really gives a sense of what I think and what many people in the trauma community think about the role of crystalloid resuscitation. So we've moved a long way. We do have blood products now, but really what comes out of this person's arm is not what's in most blood banks. The blood gets fractionated into different components, and then you're left deciding, should I give red cells, should I give plasma, should I give platelets, which one should I give first? And this has been a big debate in the trauma world, and that culminated in the PROPER trial a few years ago that showed, yeah, if we give these components in a 1-to-1-to-1 ratio, that probably is the best for the trauma patients. And so if you're thinking about giving red cells, plasma, and platelets in a 1-to-1 ratio, then why not give whole blood instead? And that's really the premise of this talk. And in a lot of ways, it's really kind of going back to and bringing the past back to the future, right? When you look at the conflicts that have happened over the last century, World War I, the only product available really was whole blood. World War II saw the same thing. When you look at the Korean War, a significant number of units of whole blood were given, as was in the Vietnam War. And it wasn't really until the 80s when we moved to component therapy. But again, with the recent conflicts, we've gone kind of full circle with the Committee on Tactical Combat Casualty Care, really recommending whole blood as the most beneficial resuscitation fluid for injured soldiers. And this is freely available. The Joint Trauma Systems guideline about the use of whole blood in trauma. You can certainly look that up and have a review of it. It's got some really good information in there. So let's compare what you get when you compare a unit of whole blood to the equivalent of what you would get with components. So when you look at the components, you get a higher volume of an anemic, thrombocytopenic, coagulopathic fluid that's really high in citrate. So really, when you compare these side by side, whole blood clearly appears to be a better product. But, at essence, we're really scientists, aren't we? And we want to be sure that we're applying the best kind of clinical care to our patients. So is whole blood any good? Well, the evidence is certainly building. I'd recommend that you read this paper by Spinella out of the military literature. This was a comparison of patients who got warm, fresh whole blood, which is kind of the norm in the military environment, as compared to component therapy. And this group was actually showing that there was certainly a lower level of citrate that was administered to these patients, which can affect coagulopathy and things like hypocalcemia. But there was a significant survival advantage in the group here at like 24 hours and at 30 days. And when you look at the Kaplan-Meier curve, there's a really interesting early separation that occurs in terms of the survival advantage. In whole blood, that's the dashed line at the top, and that kind of persists throughout the study period. This was a paper that came out in the civilian literature. It was really one of the only randomized controlled trials that we've had so far in the civilian literature out of Houston. It compared cold whole blood to component therapy. And just as an important aspect of this, at the time, the mechanisms to create that whole blood unit were such that they did affect platelet function to a degree. And so you have to take that into account in terms of the outcomes here. So although they showed a lower blood product requirement overall, they were not able to show a significant survival advantage. This is a paper that came out retrospectively out of our group as well as the group over in New Jersey. We looked at cold whole blood compared to component therapy, and certainly this showed that there was a survival advantage to getting people alive out of the trauma bay, but unfortunately no significant survival advantage towards the rest of their stay. And then more recently, this paper came out, which was a retrospective review of the National Trauma Database. They looked at patients who got whole blood as well as component therapy, which is a way a lot of centers are practicing in the civilian world, and compared that to component therapy alone. Again, there was here a significant survival advantage, however, at 24 hours, as well as during their hospital length of stay. So certainly the data is kind of evolving to show that there might be benefit, and we'll hopefully get more data as well from a joint kind of DoD study that several centers around the United States are doing with this LIGHT study group that will hopefully provide even more data. So what do we know right now? Whole blood seems to make physiologic sense. There seems to be a lower need for blood products overall in the group that get whole blood, and there may be a survival advantage. Certainly the more latest literature is pointing towards that. But the question is also, what can go wrong? We always have to look at the downsides of any new therapy as well, right? So when you look at decades of kind of use, let's look back at World War II use. So several thousand units of whole blood were utilized. Very few transfusion-related reactions or side effects, actually. And this was at the time because there was a significant knowledge about blood types and compatibility. But what was lacking early on was knowledge about antibody titers. So let's look at the physiology a little bit. So we know that there are 4 major blood groups. Each one expresses different antibodies on its surface to which antigens in the blood can react react to it. And so the majority of patients will have either type A or type O blood. And so you want to immediately, in terms of when you're looking at donors, take out the other groups because they're not very frequent, plus there's a higher risk of antigen-antibody reactions. The group A also has a high risk of antigen-antibody reactions, so they get taken out as a potential source for whole blood, and so that really leaves us with type O whole blood, and that's what we've utilized really across the years for patients getting whole blood therapy. So we really want to look at preferably type O patients, and we want to look at their antibody titers, and we can measure that now. The blood bank can do that for you, and that should be less than 1 to 256. So when you look at the hundreds of thousands of units that have been used in the Korean War as well as the Vietnam War, very few transfusion-related reactions. And more recently, when you look at the more recent conflicts, this is data from Operation Enduring Freedom that had, again, several thousand units of whole blood utilized, very few, if any, notable reactions. So not only does this make physiologic sense, might need less blood product requirement overall, may have a survival advantage, but it appears to be pretty safe. And I think that's like a testament that we've now seen over decades and decades of use. So logistically, how do you bring this about? You know, in the military, we have the benefit of having the ability to create a walking blood bank. So the ease there is that we know who the donors are, we know what their blood types are, so should a mass casualty happen, people can line up very quickly with already kind of pre-tested blood that we know what their blood type is, so we know who can be the potential donors. Again, that can actually be brought into civilian practice as well, and this paper is interesting, came out of Scandinavia, that showed that they were able to actually utilize this in the civilian setting to be able to have a walking blood bank for fresh whole blood, and certainly in perhaps more rural communities or even in urban environments, this might be something to look into. Storage with the modern refrigerators is certainly useful to allow storage of products, and that can allow a donor drive to be done, and then you have a pool of blood available to you should an event happen where you need it. So the product that we're actually using is cold stored type O leukoreduced male donor low titer whole blood. And so we use type O as we saw the most common donor. Leukoreduction technique is really to minimize the response of in terms of inflammation when transfused to the recipient. And we use male donor preferentially because we've had data that shows that female donors tend to cause a higher risk of ARDS. So we prefer male donors here. The American Association of Blood Banking does allow a longer storage period of up to 35 days now, so it means that you can utilize your blood for longer. But it's important to understand that with our current methodology, the platelet function does diminish over time, and so just be aware about that the older blood units may have a lower platelet function, and that may affect outcomes. This is our algorithm at Penn. So we have, if you're an adult male or female outside of reproductive age, and really that's there just to minimize the risk of rhesus isoimmunization, although we're talking about kind of removing that because certainly, you know, if you die from hemorrhagic shock, there's no concern for isoimmunization later on. But nevertheless, if you're in those age groups and demographics and you come in with a severe injury and you're not dead, you don't have a severe TBI, and you score 2 or more on the ABC score, which you see in the corner there, then you're eligible to get up to 4 units of whole blood in the trauma bay, and that can go up with you to the operating room as well. And in our over 2.5 years of utilizing whole blood at our center, we really only had 2 major problems, and those were both transfusion-associated circulatory overload, probably due to pre-existing conditions. So it's great to have this whole blood with us here in the trauma center, but clearly we probably have more benefit of bringing this to scene, right? And there's already several agencies that are using component therapy in their vehicles, and certainly that could be of benefit to patients, really, because when you look at this data, and I really encourage you to read this paper that showed that the most significant potentially preventable death happens early on, well before 30 minutes, in patients who have severe torso injuries. And when you factor in the average pre-hospital time, something needs to be done to prevent that death from hemorrhagic shock. The group out of Pittsburgh, PAMPER trial, really did a great job showing that, especially in patients with more prolonged transport times of 40 minutes or so, pre-hospital plasma did a much better job than, in terms of outcomes, as opposed to patients who got crystalloid instead. And actually, when they did a secondary analysis of the results, they found that the group that got both pre-hospital plasma and packed red cells did much better than the plasma alone group, and certainly much better than the crystalloid group as well. So why not just replace that with whole blood? And this was the thinking of several groups, including Thor and the Committee on Tactical Combat Casualty Care. And certainly when you look around the world and around the United States as well, there are several agencies now that are utilizing whole blood on their vehicle, and have developed kind of systems to be able to deliver that appropriately and safely. And in fact, we've had a lot of precedent from this from the cruise ship industry. I'm not sure when the cruises will get back online, but certainly up until the pandemic, they were certainly utilizing this very regularly and very successfully, and have published a few case series on the utilization of that. So just in summary, again, remember, whole blood, is it better than the sum of its parts? I think so. It makes physiologic sense. There's a lower blood product requirement overall. That's what we're seeing from the studies. It's certainly over decades and decades of use in multiple wars and in civilian practice shown to be safe. It may well have a survival advantage as well, and it can be moved pre-hospital. So certainly consider that in your planning. If you're thinking about bringing blood into your vehicles where you haven't done so, or if you already carry packed red cells, think about moving to whole blood. It may well confer a significant survival benefit to your patients. So again, listen, thanks to Eric and everybody at the FAST Symposium Organizing Committee for the invitation to speak to you guys today. I really look forward to speaking to you guys in person in the near future. And I'm always open to answer any questions. Feel free to reach out to me at any point. Thanks so much.